We're next going to demonstrate using a gait belt for ambulation and transfers. There are many different styles of gait belts available depending on the facility where you work. Some have a metal clasp on the end and it's just a simple canvas belt. There's the same model of a canvas belt with a plastic clip on the end. And then there's a more complex belt that's a little bit wider with handles for the caregiver to hang on to. So depending on what your facility uses, you will see any number of these different styles of belts. We're going to just demonstrate the simple metal clasp belt, as this is a pretty common one. What you're going to do is get the patient to sitting. The gait belt will go around their waist, and the belt will go over the teeth side of the clasp first for buckling. Contraindications to using a gait belt might include someone who's had abdominal surgery or back surgery where they can't tolerate that, or a colostomy bag, but usually the gait belt is tolerated well. The gait belt does not make someone walk who can't, and it will not make the caregiver have superhuman strength. It is purely just a handle to keep the gait belt around the person and us in contact. The extra tail of the belt can be tucked in so that it is not in the way or causing a trip hazard depending on how long it is. We're going to have the patient move from sit to stand, and if they have a difficult time initiating movement, you can raise the bed up to get the hips above the knees a little bit, which oftentimes makes it easier for the patient to stand up. You want to make sure that they have good contact with the floor with both feet so that they're able to stand up. They may push from the surface to initiate the movement coming from sit to stand. Once in standing, it's a good idea to get the person to just hold the position for a moment or two. They may march in place a step or two to make sure that they do not have a problem with dizziness or fainting. Hand contact at the gait belt is so that the hand is not tucked all the way into the gait belt, so that if a fall occurs, the caregiver is not pulled to the floor as well. So you do not want to have the arm tucked into the gait belt, but you want to just hang on to it so that you can release it if you need to. The second hand could be on the side or front of the gait belt, or you may hang on to the patient's hand or arm, realizing that if the patient is to fall away, hanging onto the arm may cause injury to the patient. It is important to make sure that the patient is not too far behind the caregiver. We don't want the caregiver to be so far away that she cannot control or be pulling the patient down the hallway. The caregiver will stand facing the patient. Using a side step motion, she can step forward, allowing the patient's feet to land between her 2 feet as she walks. This allows her the ability to control direction, turning slowly as needed. Turns are a frequent area where patients will lose their balance. As she's able to walk, if she loses balance, we can simply pull her back into our base of support. By keeping the patient close, if she starts to lunge away, we can bring her back over our base of support. We can call for help if needed. But if the patient begins to get unsteady, confused, glassy-eyed, unable to answer simple questions, we're going to stop the activity and call for help. If the patient begins to fall, we're simply going to let her lower down as far as the caregiver can comfortably, extending the arms towards the floor, and when she's where she can no longer safely lower, we're going to let go of the gait belt and guide the patient down, protecting the head. There is no way to safely stop a fall once the patient begins to fall. We want to try to soften the landing as best we can, and then potentially use the total lift to get them up from the floor.